Hello everyone. I will be doing a case study presentation on a patient with heart failure. So this slide is on epidemiology and pathophysiology, but I want to start with what heart failure is, which is when the heart is unable to pump or receive blood effectively, leading to inadequate perfusion of organs and tissues. Heart failure affects about 6.7 million adults in the US. Higher prevalence is in older adults and in Hispanic populations due to higher rates of hypertension and diabetes. Certain medical conditions increase the risk for heart failure, and these are CAD, myocardial infarction, hypertension, obesity, diabetes, and other types of heart diseases. So pathophysiology for heart failure is involving various mechanisms, but this is developed from underlying heart diseases or conditions that strain the heart. This causes an activation of the renin-angiotensin-aldosterone system, stimulation of the sympathetic adrenergic system, vasopressin secretion through beta receptor mediation, leading to excessive water absorption, and that's why they're getting more swelling. Persistent elevation of inflammatory markers resulting in fibrosis, maladaptive intracellular calcium handling, ATP-related energy depletion, and increased production of reactive oxygen species collectively exert detrimental effects on the left ventricle. So then the left ventricle has dysfunction, which leads to the pulmonary congestion, and it results in the symptoms of shortness of breath, orthopnea, and peripheral edema. For the subjective part, we have a chief complaint of increased shortness of breath when walking short distances and swelling to the bilateral lower extremities. There is also an inability to sleep when laying flat. The patient is a 68-year-old Hispanic male presenting with increased shortness of breath and fatigue. The patient noticed an increase in shortness of breath when walking short distances, and this isn't normal for him. He also says that he needs to sleep with his head propped up because if he doesn't, he feels like he can't breathe. He also noticed more swelling in his lower extremities. For allergies, he has no allergies documented. For medical history, he has obesity, hypertension, hyperlipidemia, myocardial infarction, chronic kidney disease, and diabetes. He has no surgical history. Family history is that his mother has type 2 diabetes, hypertension, and hyperlipidemia. His father has hypertension and hyperlipidemia, and he had a CVA. For social history, the patient drinks beer occasionally for leisure, but he denies smoking and illicit drug use. For medications, he's on aspirin, lisinopril, atorvastatin, metformin, multivitamin, and a calcium. For the review of systems, he denies any fever or chills. He denies any headache. For respiratory, he reports increased shortness of breath. For cardiovascular, he denies any chest pain or palpitations. For the peripheral vascular, he reports an increase in lower extremity swelling. In neurologic, he is denying weakness or tremors, and he's alert. So for the objective slide here, we have the vitals, which is temp of 98.8, a blood pressure of 146/91, the heart rate is 94, respirations are 24, oxygen is 95%, and no pain. The BMI is on the higher side at 38.7. For physical exam findings, he appears tired, obese, but maintains good eye contact. He has crackles to the bilateral lower lobes and dyspnea on exertion. For cardiovascular, he has S1, S2 without murmurs or rubs. For peripheral vascular, he is positive JVD and +2 pitting edema to the bilateral lower extremities. For the musculoskeletal, he has a normal curvature, full range of motion on all extremities. He is alert ×4, no focal deficits, his face is symmetrical, and has clear speech. For the diagnostics, the BNP is elevated at 214, and the chest x-ray shows pulmonary congestion. The echo resulted with 40% left ventricular ejection fraction. Here I have the differential diagnosis listed, with the first being heart failure with reduced ejection fraction, since he is having shortness of breath, inability to lay flat, and bilateral lower extremity swelling. The second was pneumonia, since he has crackles to the lower lung lobes, shortness of breath, and the x-ray shows pulmonary congestion. Third being pulmonary embolism, because he has sudden shortness of breath and BLE swelling. The fourth being venous insufficiency due to the swelling in the lower extremities and obesity. The fifth being nephrotic syndrome, since he has CKD already and having bilateral lower extremity swelling and fatigue. For the assessment part, we have the ICD codes and the diagnoses, which primary diagnosis was unspecified systolic congestive heart failure. Other diagnoses were class 2 obesity, other malaise and fatigue, dyspnea unspecified, orthopnea, localized swelling, mass and lump, lower limb, bilateral. First stage C heart failure because he is having symptomatic heart failure. He's also on the New York Heart Association of Class 3. Due to marked limitation of physical activity and is comfortable at rest, the usual daily activities causes fatigue and shortness of breath as well. Comorbidities are obesity, hypertension, hyperlipidemia, CKD, MI, and DM type 2. The treatment plan for this patient is to discontinue lisinopril and continue the rest of the current medications he's taking. Medications that were ordered were Lasix 20 milligrams daily, dapagliflozin 10 milligrams daily, Entresto 24/26 milligrams BID, carvedilol 3.375 milligram daily, and spironolactone 12.5 milligram daily. There was also a plan to restrict sodium about less than 2 grams per day to reduce swelling. Daily weights and exercises tolerated, avoid NSAIDs, alcohol, and smoking, and to refer to cardiology for follow-up, a nutritionist, and diabetes educator for better understanding with diabetes. Evaluation of this patient is important as a practitioner because he has a lot of issues. We're going to have to monitor patient symptoms such as if there's improvement in shortness of breath, edema, and exercise tolerance. We also got to track adherence like medications that were taken, the current diet, and if attending all his follow-up appointments. We got to order labs and diagnostic follow-ups such as renal function, hemoglobin A1C, TSH, since he's fatigued, electrolytes, especially potassium, since he has CKD and he's taking spironolactone, lipid panel, BNP, and echo are as needed if his presentation is worsening. And then we're going to adjust the plan based on the patient outcome. Patient education is very important. The patient was educated about heart failure and told that the increase of shortness of breath and bilateral extremity swelling is due to fluid backing up into the lungs and legs, since the heart is weaker and not pumping as well. Tips given were to weigh himself daily and call the clinic if he gained about 2 to 3 pounds overnight or greater than 5 pounds in a week. Limit salt intake, since salt increases water retention. Stay physically active. Take all meds as directed, even if he feels better. Elevate the legs when resting to help bring up pooled fluid in the bilateral lower extremities and to avoid alcohol, NSAIDs, smoking, and drugs. Here I have a list of the references used for this presentation. I hope you guys enjoyed this presentation and thank you so much.